Blair, thank you. That was excellent. Our next presentation will be from Ross Bremner, and Ross is going to talk to us about pulmonary dynamics and pulmonary manifestations. Oh, there you are. There you are.
So how does this work? There we go. Thanks very much. I'd like to thank the organizers, and thanks to Reg and John and Sumit for putting together such a great conference. I have no conflicts. Like many before me at this conference, I'm lamenting the fact that I only have about 15 minutes to cover this topic, because there really is a lot to say. In fact, we'd like to put a whole conference together on this. However, since I understand many of you are surgeons, and like myself, you probably have the attention span much like that of the average-sized gnat, and I was pleased to hear this morning that most gastroenterologists don't have much more patience than we do when they do endoscopy. So 10, 15 minutes may be more than enough. So overview, I'm just going to talk a little bit about the pressure dynamics in the chest and the abdomen. We've talked a little bit about this transdiaphragmatic pressure gradient. I'll touch briefly on cough and my thoughts on that. You've heard some wonderful talks on LPR. And then aspiration, but I really want to spend most of my time talking about this unique population that I have access to, because as I grew up with my father, Cedric Bremner, in a family where the dinner table conversation was frequently centered around Barrett's and reflux, and I subsequently spent more than a decade under the tutelage of Tom DeMeester, I actually consider myself indoctrinated in the world of esophagus. And I sympathize, I empathize with most of you who believe that the esophagus is the center of the universe. But after I moved to Phoenix, I found myself engulfed in the world of lung transplantation, and it's really been a wonderful opportunity for us to take my understanding and my background in esophagology into the transplant world. So I'll share with you some of our recent publications on the pulmonary dynamics from this very, very interesting population of patients. So just to put this in your mind again, this is the thoraco-abdominal pressure gradient, or the transdiaphragmatic pressure gradient. This comes from a recent publication that we did with Sumit. But really, as this pressure gradient increases, your DeMeester score increases, the number of reflux episodes increase, total time of pH less than 4 increases. There is a significant inspiratory negative pressure gradient in just about everything that we do. So when we breathe, which sitting in a conference room like today without doing any exercise is about 20,000 times a day. It's almost half a million times in 60 years. And each breath generates at least negative 10 millimeters of mercury. We've got some sound there, I think, right? When we swallow, the esophagus gets shortened, and that exposes the lower esophagus to these intrathoracic. Wow, that's loud. That's very loud. Proud of me, right? Okay. All right, when we cough and sneeze, you increase incredible transdiaphragmatic pressure. And as, I'm not sure what happened there. As Tom DeMeester said yesterday, or this morning, you pick up a bag of cement, you can generate incredible intra-abdominal pressures. Further, as we get into our epidemic of obesity, the increased intra-abdominal pressure was mentioned this morning as well, is associated with increased GERD. We haven't talked much about sleep apnea, but this, I think, is associated with obesity. We're seeing more of it. And not only does it increase the reflux that we see in these patients, but I think that it puts some of our repairs under tension, as I'll show you. So with time, it's very little surprise that a hernia becomes normal as we mature, as I'd like to speak to my patients. And if you get old enough, you'll all have a hernia, as this phrenoesophageal ligament stretches and the proximal esophagus enters the abdomen. What is the association between reflux and pulmonary disease? Well, there's a lot of things that are associated, and we can't have time to go into these, but you've seen the laryngeal edema, hoarseness, malacia, stenosis. We get lower down into the airways, as tracheitis can make asthma a lot worse, bronchiectasis, bronchiolitis. We get into the lung parenchyma, we start getting pneumonitis and ultimately pulmonary fibrosis. As a lung transplant surgeon, we've actually transplanted patients who have end-stage pulmonary fibrosis as a result of a lifetime of chronic aspiration. So the upper respiratory tract symptoms are hoarseness, sore throat, difficulty swallowing, chronic cough, again, globus, halitosis, chronic throat clearing. Lower symptoms, wheezing, dyspnea, chronic cough, sputum production, sometimes fever and malaise as we enter the bronchiectasis part of the world. So chronic cough actually has a definition. It's a cough that lasts more than 8 weeks. Its prevalence is really quite common, more than 12% of our population. It's the single most common symptom referred to pulmonologists. And GERD is one of the most common causes of chronic cough. So there is definitely a close association, although it has been difficult to unravel. And 50% of patients with chronic cough show an association between cough and reflux during reflux monitoring. As Blair alluded to, it's a significant problem in our society. Many of these patients get socially isolated. It's associated with clinical depression, incontinence, syncope, nemesis. So what's the pathophysiology of GERD? Now, this probably should be in Reza Shaker's environment, but it does take me back to the time when I did my PhD thesis in Tom DeMeester's lab. And this is the ambulatory motility showing a cough which precedes reflux, and below you can see reflux which precedes a cough event. So clearly these two are associated. Chronic coughers have more reflux, and chronic refluxes can have a chronic cough. There's two really main theories for why we cough. One is the obvious aspiration theory, where reflux enters the laryngeal adductus and causes inflammation. The other is quite interesting. It's a reflex theory, because the esophagus and bronchial tree have identical embryologic derivations, and they share a common innervation, as Dr. Shaker will tell us, via the vagus nerve. And the stimulation of receptors in the distal esophagus by the refluxate can lead to a vagal reflex, which can lead to bronchial constriction and cough. Both of these probably play a role. But just to take 1 minute and talk about hypersensitivity, this is a study that was done by Javorka and colleagues, where 18 healthy subjects without GERD or cough underwent an infusion of the esophagus with saline and acid via a nasogastric tube, and each followed by a capstan challenge. They showed that acid infusion did not affect a cough reflex in these patients. They then took 16 patients with GERD who didn't have a cough and 9 patients with GERD who did have a cough. They did the same experiment, and they showed that acid infusion increased the cough reflex sensitivity only in those patients with GERD and a chronic cough, but not in the patients with GERD and no cough. So pause for thought, right? So how do we treat these patients? Well, I think what I'm going to do is send them over to Blair Jobe, since he's got a whole team to take care of them. These patients can be very difficult to take care of, and to get to the bottom of them does take a lot of patience. Do we target PPI? Well, there's really insufficient evidence to conclude that PPI treatment is beneficial in treating non-specific cough. But I think in patients who may have regurgitation or reflux, it's not unreasonable to do it. The meta-analysis, the standardized cough scores with PPI therapies, you can see there. In fact, there's some really not very clear data in a general population. But this is something one of my pulmonologists taught me about a few years ago. That's targeting the hypersensitive cough reflex by adding gabapentin to their regimen. So gabapentin for refractory chronic cough is studied in a randomized double-blind trial, as you can see here, both in Australia, and it was presented in the Lancet. And 62 adults with refractory cough was randomized to receive gabapentin. They increased the dose over a period of about 10 weeks. And the primary endpoint was a change in cough-specific quality of life. Gabapentin significantly improved their quality of life. This is another study that did the same thing. Found that 75% of patients with gabapentin experienced at least a 50% subjective improvement. So even patients with documentation of GERD could respond to treatment targeted towards an abnormal cough reflex instead of simply treating GERD. So keep this in your armamentarium. It's a relatively benign drug. You can add it to PPIs, and that many of our pulmonologists have had quite a lot of success with these patients. Opiates is a slippery slope, and I'm not going to get into that. What about anti-reflux surgery? It's weak acidic reflux can get up without abnormal pH scores, and it's been talked about a lot by the two previous speakers. Because you really only need one aspiration event. You may only need one aspiration event every week, because it's incredibly irritant to the airway, and once you set up the cycle of chronic cough, you've got a big problem. And anti-reflux surgery is probably the only way that we can really inhibit reflux from entering up into the upper esophagus and to the pharynx. But as Dr. Karillis pointed out in his study shown here, that none of the studies of anti-reflux surgery reporting benefits were placebo-controlled. So we're probably a little remiss in not studying this better. You played the first video? But I'm going to ask you, PPIs suppress aspiration here. This is a patient of mine that has sleep apnea. There you can see us looking down at the hernia. And then I pull back my scope into the esophagus and play the esophageal, the second video, please. So you can see as he snores, this refluxate pours back into the esophagus. Show the next video. I've got the next slide. So this is a patient of mine that had an anti-reflux operation, gained 40 pounds. And I thought, wow, his RAP looks good. When we scoped him, he had these areas of sleep apnea or obstructed his airway, and you can see what happens when his airway is obstructed and he developed negative intrathoracic pressure, pulled the whole RAP into the chest. The interesting thing is that when we did a jaw thrust and opened his pharyngeal airway, the RAP popped back down into the abdomen. I think this is something that has not been studied very well, and probably something we as surgeons need to think about in our patients who are becoming increasingly heavy and carry their BiPAP machines around with them whenever, as they go through the airport. So this is my pulmonologist stepwise treatment to chronic cough. They give PPIs, Gabapentin, and then they're very quick to send them to us if they think anti-reflux procedure. We won't get into assessing aspiration just in the interest of time. I'll talk for a couple of minutes about a lung transplant population, because the dysmotility and reflux is much higher in the transplant population or the transplant candidates than the average population. And we know that even small amounts of aspiration really affect the short and long-term outcomes after transplant. So it's well known that a small amount of aspiration can incite chronic rejection or bronchiolitis obliterans syndrome, and that decreases the lifetime of the donated organ. So this is that thoracoabdominal pressure gradient again. Well, we've got two interesting subsets of patients that we commonly transplant. One of them are the obstructive lung disease, such as emphysema. These patients have a chronically increased intrathoracic pressure. They purse lip breathing, so they're trying to get air out of their lungs, right? That's an oomph sign. The restrictive lung disease are completely opposite. They've got tight chest, restricted lungs, and they're sucking air in. Now, you can see this very clearly on the manometry because they've got great pressure changes in the chest. So we wanted to study whether the pulmonary dynamics after transplant affect esophageal motility. We took a couple of years' worth of patients at our transplant program, and we looked at the two groups of obstructive and restrictive lung disease. And we studied them all with complete pulmonary functions, foregut testing before and after transplantation. Some of these patients couldn't undergo complete testing because they're critically ill, but of the 112 patients over that 2-year period, we had roughly half of them in the obstructive lung disease and half in the restrictive lung disease. You see that the thoracoabdominal pressure gradient, as you would expect, is much higher in the restrictive lung disease. They're decreased, they're trying to suck air into their lungs. But the interesting thing is after transplant, it all normalizes. Similarly, obstructive lung disease, which have a slightly lower thoracoabdominal pressure gradient, it improves after, it gets back to normal after transplant. The interesting thing is that the motility actually invariably improves. So the peristaltic vigor in these patients invariably improves once the pressure dynamics have normalized after lung transplant. And in fact, some patients who had a small hiatal hernia noted pre-transplant, post-transplant, there was no evidence of that hiatal hernia. Esophageal length is longer in obstructive lung disease patients, and it's shorter in restrictive lung disease, and it normalizes. So this just summarizes that. The reflux associated with it is very high in patients with restrictive lung disease pre-transplant, very negative intrathoracic pressure. Post-transplant, they still are refluxing a lot, and we think that this is partly because about 50% of them have delayed gastric emptying. So in some patients, the gastroesophageal reflux was improved after transplant, but in others it was exacerbated. Before transplant, significantly worse acid exposure in the esophagus seen in patients with restrictive lung disease, as I showed you. And the differences change when we normalize the pressure dynamics. So in summary, more exacerbated esophageal acid reflux is associated with a higher trans-abdominal pressure gradient. And on high-resolution manometry, anti-reflux function was improved after transplant. So our hypothesis is that when your esophagus is stretched in either the longitudinal or the transverse position, that it affects motility. I'd love to discuss this with Dr. Shaker. But afterwards, when this is all normalized, the motility improves. Has a great implication in transplant because historically when we study patients preoperatively and they have poor motility and reflux, we tend to think they're not good transplant candidates because we're not going to be able to do an anti-reflux operation after surgery, and they're going to be aspiration risk patients. But we now know that the motility improves in many of them, and even in some patients with a completely aperistaltic esophagus, in the absence of connective tissue disease, they will restore some of their function afterwards and allow us to do an anti-reflux operation. That's really essentially the conclusions. Thank you.